Thanks everyone for coming to DPC at Scale. My name is Kate McGinley. I will let my fellow panelists introduce themselves if they want to real quick, and then a little bit about their background, and then we'll get into the discussion.
Okay, I guess I'll start off. First off, I have to say is whatever happened to It Never Rains in San Diego? I mean, this doesn't make sense, right? But I used to be in the Army, so there was a lot of things that we did that don't make sense, so I can roll with this. So I guess I let the cat out of the bag, so I was in the Army from 1995 to 2000, exited the military and went into corporate America. And in particular, the last 20 years, since 2003, I've been in the healthcare space. Been with many of the big companies, so I've been with Pfizer, been with Guidant, been with Boston Scientific, been with Abbott. One of the things that we say when we're talking to employer groups is that the DPC model, it rescues the patient from the system, and it also rescues the provider from the system. Well, one of the things that DPC did for me was it rescued me from corporate America. And so there's nothing more fulfilling in knowing that the job that you have is having a huge impact on changing the way healthcare is delivered in the country. So that's something that I really enjoy going to work every day because that's what we're doing. And one of the things, because I know we're going to talk about scale here, and to scale, you have to have the right people in the correct positions. And that's one of the things that I've been blessed with at Primary Health Partners is we have a phenomenal team. And that goes back to when we were founded in 2016, in January 2016, by our two co-founders, Dr. Rickner and Dr. Lockwood, actually great people. Then it also goes, I'm going to single two people out who are here today. So Candace LeBrun is our CFO and our COO, and we would not be where we are today without her. She does a tremendous job. And then we have Lacey Belanchek, who's our project manager slash data analyst slash hint intermediary slash affiliate coordinator slash whatever we need done. But we really have a phenomenal team, and that's one of the things that if you're looking at scaling, you're going to have a good team in place.
Thanks, Rocco. Ryne?
I'm Ryne Bessmer, president of Strata Healthcare, and I don't know that I have as rich of a history as he does and background, but I come from a family business. I don't know if any of you are in family business. I'm sure a lot of you are. And I've had the pleasure of getting to work with my dad and my mom, growing Strata since 2016. Back in 2016, my father, being a concierge physician, saw Dr. Clint Flanagan growing Nextera out in Colorado and said, we should go talk to Clint Flanagan and figure out what he's doing and try and emulate that. And since then, we've really grown, and excited to talk to you today about the different ways that we've been able to do that.
Thanks. Mark?
I'm Dr. Mark Tomasulo, family physician, founder of Peak Med back in 2014. Recently acquired by One Medical about 18 months ago. Now the head of DPC strategy and innovation for One Medical, trying to roll out national DPC strategies. So lots to talk about.
Oh, yeah. So this morning, we had a great conversation over breakfast, and we were all talking about scale, right? So does anyone here come out of academic medical centers, or have you spent time with any of the BUCAs? Raise your hand if you have, and if not, more power to you. Okay, similar, all right. So when we think about scale, right, we're all thinking about scale very differently. And one of the things that the four of us thought would be most impactful for the audience is getting your very first employer clients, right? My company, I'll share, we just landed an employer client the other day. It's going to be 300,000 individuals coming through, right? That's a huge scale. These guys have done similar things, right? But we all had to start with that very first client. So we really want to focus today on getting your first 50 to 100 life employer group. And so I'd like to ask these guys, you know, when you think about scale, how did you first think about scale, right? What was the impetus for that? Were you thinking about member lives? Were you thinking about revenue? Just when you say scale, what were you first thinking about? So.
There's so many ways that you can take that question. So looking at typically the smaller employer groups, there are groups that you can add pretty quickly. So one of the things that we're trying to change is the mindset out there when we talk to the bigger employer groups, say over 500 employees. They think that they can only do it because it's a benefit one time a year when they have renewal, and it's not the case, but we're trying to change their mindset. But when we're going after the smaller employer groups, say the 50 to 100, you can have a much quicker impact. So you can really sign them up the next day. And so that does happen, and when we think about the value that we're providing to them, it's really the utilization. So in other words, they're paying for the access and convenience of direct primary care, but their employees are actually utilizing us. And that's one of the ways that we can show value to them, because the last thing an employer group wants to do, whether they're small or big, is pay for a benefit that their employees aren't using. Yep. And that's one of the things that the direct primary care model really lends itself to, is the utilization. So that's where we're really having a big impact with the smaller groups.
Yep.
I think from my perspective, I think the most important thing to understand scale is based on where you are in your practice. If you're just starting, your scale is maybe 50 people or 100 people. If you're a little bit bigger, now you want to go to the next iteration level. I think the biggest factor for us was always knowing who we were talking to. If we were talking to a business that looked like me, had 10 employees or 15 employees, is very easy. It's a conversation. It's not a sale. It's just an education. And you can walk away from that meeting knowing whether or not they're coming on board or they're not. I think when you start talking to larger organizations, and I think the defining moment for me was anything that's 50 and over and they're mandated to have an insurance plan, you've now hit a totally different hurdle and gate to have to go through in order to close those types of clients. And I think the client that's 50 employees all the way up to 5,000 employees, it just gets a little bit more sophisticated in the conversation, but knowing who you're talking to and how to motivate them onto this product and befriending our brokerage community. Yeah. Like, you have to make best friends with a broker or two. Volume is not your friend in a broker business, in all fairness. You want to have a handful that really believe in what this thing is and defend yourself against the ones that want to just learn to sell against it. Mm-hmm. So really having a valuable relationship with consultants and brokers to really show the value proposition that DPC provides to them is a huge key to scale, I think, whether you're closing a company of 10 or a company of 10,000. Yep. It's very similar.
Sure.
Yeah, we had to think about scale early on in our company. Our first employer group, I remember meeting with them. They had a couple hundred employees. It was a plumbing company. I think we've showed their data here at one of these conferences in years past. And they came to us and they said, we're not going to send all of our employees to one clinic. We need to have more options than this. And we're like, well, we don't want to, that's expensive to open more clinics in a town like Omaha, Nebraska. And so we went around to the local physicians who we knew, who were independent, not owned by hospital systems, and said, do you want to participate in this DPC offering? Here's what it looks like. And started to grow our affiliate network from there. It started right in Omaha, and it's since grown through different employer demands. But yeah, that for us early on, scale was how many clinics are we going to need to service our employer groups? Mm-hmm. Today we think about scale a little differently. We still have our affiliate networks, but we're thinking more so of like, what are the different services that we can provide to employers that they're asking us about, whether that's different wellness initiatives or telemedicine, and ways that we can grow our product offering as a healthcare company.
Makes sense. That's great. And so, Mark, you brought up something interesting. I want to touch on this, right? Demonstrating that value to employers, right? And understanding at a certain group size, it looks very different. So I think as a provider, especially, your perspective here is very interesting. Could you share a little bit about demonstrating value to the employer and your thoughts as a provider on how to do that?
Yeah, I think what made us very successful in growing the practice was I was a physician relating to another human being that just happened to be a CEO of a company, telling him I hate my life. My job sucks. I don't like it. I left the practice of medicine, in the traditional sense because it's miserable. And I think it's important for people to understand, medicine in the traditional sense is not very sexy, right? It's a business, but they're all compassionate at a human level. So I think having like a very open, honest conversation and like throwing out your why of this thing. I could tell you we have hundreds and hundreds of clients. I have never ever explained this to any of them or any of our sales team or any of our clinical team, explain this concept of direct primary care to anybody and said, that's the dumbest thing I've ever heard. No one has ever said that. Right. They've always said, well, why isn't everybody else doing this?
Right.
And how do we do this?
Right.
Then it's a very simple close from a transaction, to now we have revenue coming into the clinic from this sale. But I think the real art of that conversation is understanding how big is the company, what's the complexity that you're trying to solve for. I'm going in, I was very naive, going in and going, we can save you 50%, right? I don't know what the hell that meant. And it actually makes the conversation go sideways, depending on who you're talking to. And these smaller businesses, they don't care, Rocco's to point this morning, they don't care about saving 50% because right now they're not paying anything for healthcare. So you're going to say it's going to cost you, $600 this month to take care of your 10 employees. Well, that's a lot of money to a small business. So having the conversation with the person that's sitting in front of you in a different way versus having a consultant that's representing a client that's 100 or 200 or 500 lives, they're looking at it from the angle of, what's this going to affect me? How is it going to affect me? Mm-hmm. Is it going to cut out of my commissions? Are we, I want to lower premiums. Well, if I lower premiums, guess what I also do with a consultant? I lower potentially some income that they have coming in. So understanding who you're talking to, how you're talking to them, and what everybody's objective is, I think makes it a little bit more successful in closing the question of how do you grow your practice or how do you scale through employers. And I could tell you our biggest success rate has always been small businesses, small employers. You get 5 employees or 10 companies that have 10, and before you know it, you have 20 or 30 or 50, and it's this water cooler effect. It starts to spread. And as long as you keep your reputation and as long as you keep your services and understand you are replaceable, provide the product that you're selling and stand behind it, people start buying it. It makes it a lot easier, and then getting into bigger conversations with brokers, that's I think a whole nother level of conversation, but scale based on who you're talking to depends on the client that's in front of you.
That's great. And it's interesting that you're talking about, based on who's in front of you, because Ryan, you brought up something this morning too. Oftentimes it's so easy to go and want to sell a whole program to an employer, but Ryan, you shared a story where you don't need to sell the whole enchilada. Maybe the employer just wants some on-site clinics. So could you share that?
Yeah, we've learned over time that what we're pitching, direct primary care, they may not totally understand, and they may be looking for something else. An example of what we've done for some larger companies is they're interested in having an executive physical for their top tier executives. And in years past, we were like, that's not what we do. We're a direct primary care company. And now we look at it differently because we're like, hold on. If we can do your executive physicals for you this year and we get to know you and there's a relationship, next year we're going to come back and talk to you about how do we do this for more of your employees and take care of you. So over the years, we've definitely broadened our scope of the way that we think about approaching employers to be more, how can we help you? How can we use the tools that we have to serve you? And it may not always look like giving all of your employees direct primary care. In the first couple of years, it may just be a couple things to get your foot in the door and then to grow it from there.
Perfect. And then Rocco, so this morning we were also talking about, as you grow your practice, right, things that you should think about as you expand your relationship with employers. You've expanded quite a bit, right? If you could think of 3 things that you would love to have known, right, as you expanded, what 3 things would they have been?
Really, what we would like to boil it down to is getting the timing lined up. So in other words, when we're expanding, and we're finding this now, so we have 8 Oklahoma City metro clinics, and this year we opened 2 clinics in Tulsa. The 3 things that we would have liked to get better clarity on is there's really 3 things you need. So you need to find a provider, you need to have a physical location, so a clinic, and then you need to get employer groups signed up. So it's really getting the timing of those three in sync, which we were able to do so far with 2 of the clinics. And you know what our goal is next year is to open another 3 to 4 clinics in the Tulsa area. But it's getting those conditions to line up to where you don't find a location and then you're paying rent and you don't have a provider there. Or you have a provider, you have a location, but you don't have any business. So it's really getting those 3 to line up at the right time.
That's great. That's perfect. Ryan, Mark, how about the both of you? Because this was a topic we really spent some time on.
Yeah, I think timing is a huge component of it because you can't go bankrupt because then it doesn't solve anybody's problem. I think the things that I've learned that I think are most valuable is being malleable in these processes of growth. You might have a very solid plan of what you think you need to do and how you need to grow, whether it's opening 2 clinics or 3 clinics. Understanding that you have to be flexible in this process. I could tell you one of the biggest things that we're having to do today, and we're pretty large, is restructure how we charge employers for our services. There was a point in time where, listen, if you have 1,000 employees, you're going to pay me for 1,000 employees. My job then, to Rocco's point, was we're going to get up to 60% engagement within the first 12 months. So we built an entire team that does everything from outreach to engagement to client services to management just to get the person in the clinic one time. Because then once you get them in one time, we can show you statistics on how much they use the practice. And that worked for a while. It's still working today, but the larger groups that we have, you're talking, now you have an employer of 5,000 or 10,000 lives that are joining the practice. They're not writing a check for $600,000 a month in the hopes that you can get utilization.
Right.
So we're having to change the model and get more sophisticated and say, listen, we'll create a utilizer model for you. You're going to give us 100% of the population. We're going to charge you an administrative fee to service this thing. But as soon as you get engaged in the clinic, now we're going to start flipping into a different economic model, which de-risks the employer's perspective. And it gives us the upside because I'm not going to charge you the same amount that I would if you were paying me 100%. You're going to pay me a little bit more. There's a risk reward to this whole process, and you have to have that balance. But I think that's kind of when you start getting to these larger employers, you have to become more sophisticated in your pricing and your concept, and understand it from the lens that they're looking at. So it might not be the way that I would love to do it from a business perspective, but we just want the opportunity. And it's our job to then go close that opportunity with as much engagement as we can. So I think that's where the market has changed for us personally over the last year. And it's changed the entire workflow. It's changed the entire, operations and processes to support that type of contract, logistics and clinical, support. And it's pretty complex, but I think that's the biggest thing that I've learned is be flexible.
I like it.
Yeah, similarly for us to build on that, when we started, I think what I wish we would have known was to be more flexible in the services that we can offer, maybe even in some of the payment structures like you talked about. And we would go in, and you probably have all realized this or experienced this, where you go in and you feel like you have to first teach them what is direct primary care before you can sell them direct primary care. And today we go in with a little bit of a different approach, which is, what are you looking for? Like, how can we help you? And something may bubble up that then you can explain how direct primary care can solve that problem. Or maybe you'll realize that you can solve their problem a different way. But for us, our KPIs over the years have now been less about how many members total do we have, but more so how many employer groups are we working with? Because we trust that over time, if we have a group for long enough, they're going to use us for more and more services, and the relationship just gets deeper and deeper.
That's great. And so it's interesting as we talk about going to these employer groups, you're all sharing, there is a lot of operational and marketing challenges that a group can face. So as a business owner, right, when you think about scale, one of the things that you want to think about, especially early on, is pricing. So again, going back to when you first started out or when you first got those earliest employer clients, what do you wish you had known about pricing back then? Because that to me is one of the hardest parts of starting that business. So Mark, you want to start?
For me, when I started the practice, I mean, in all fairness, I funded the company out of my piggy bank, right? So for me, $50 was better than no bucks, and I would do it for 10, because it was about paying a bill. I think as we matured, and in all fairness, I was telling you this morning, we probably have, 30 companies that started with me 10 years ago, and I still charge them $50 to this day. I will not increase their pricing, right? I just feel like I have a debt of, gratitude to them. But I would never do it for $50 again. And the reason is because there's a cost to doing the business, and we're not going to help anybody if we're undervaluing our product. And I think it's almost counterintuitive to the psychology of people is like if you're buying a product for $10, there's an expectation that you're getting a $10 product. Mm-hmm. I don't think you should buy a $200 product for a $10 service, but there is a balance in terms of what your value is. And I don't think as physicians we should undervalue what that is, right? I've always wanted to protect the competition in the market to say, let's not have a race to the bottom. Like I can do it for 64. No, I could do it for 62. And before you know it, we're back to $50. I think there is a value of physicians that we put on the practice and what we're offering. And sometimes, it goes it's a bell curve. You have some people that are charging hundreds, and I could never grow a practice doing that. And then there's some people that give it away, and you can't survive a practice doing that. So somewhere along the line, there's a bell curve in that. I just think that you have to market specific. You know exactly where you live. You know what the cost of living is. You know what your competition is charging. Stay somewhere within that, but don't be afraid to defend the idea that your time is valuable. I try to equate it to like an attorney. My attorneys charge me $350 an hour, whether we're chatting about our kids or I'm actually asking for legal work. I get a bill for $350 an hour. In all of DPC, if I'm charging $60 and I'm spending an hour with a patient, put that in perspective for a minute. It's a fraction. So don't be afraid to ask for your value. Just be reasonable.
That's great.
Yeah, our pricing has been $99 for the first adult, and we haven't changed it over the years. We haven't really talked about changing it over the years. It's pretty much worked for us, and the only thing I'll say on top of that is just to say that when you do have more of a premium price, because I think at our $99 we're more on the higher end, employers want reporting from you, and so if you're going to be out there working with them, you need to think through, okay, if they're spending $1,200 a year for an employee to be in this, I really need to be demonstrating them value. To your point about the 60% utilization, they want to make sure that if they're paying for these memberships, that the people are coming in. So if you do have a price that maybe is on the higher side, be thinking about what's our strategy to get people in and engaged with our clinic from this employer group, because the employer is going to want to at minimum see the engagement data. They may want to see some claims data, and we can talk about that privately, but have a strategy for engaging.
So my one piece of advice, and I know Candace, our CFO, would agree with me, is keep it consistent, because we're talking about scaling here. So don't do different prices for if an employer has, say, 1,000 employees versus someone that has 5. It's going to be a nightmare managing that. So when you're thinking about your pricing, keep it consistent.
That's great.
I would just add to that one thing, though, is employers that are giving you 500 patients or 500 employees don't want to pay a consumer price. So if you have a market consumer price of $89 or $99 and an employer comes to you and says, we're giving you 500, we're not paying 89, the answer is okay, I understand that. That's perfectly fine, but let's bring it down a little bit. So there are price breaks. It's just depending on what your drivers are for your practice. If you want to be a consumer business, then that is a strategy. If you want to be an employer or an enterprise company, DPC practice, that is a totally different strategy. And then depending on what kind of employer you want to have is really where you start teasing out where you can be successful inside of this thing called scale in DPC.
I love that, because they are two very different go-to-market strategies, right? The consumer-facing, which I think that's a great place to first get that initial traction, find out what drives your members, engages them, get the practice up and going. But then to all of your point, that employer side, it can be a very different relationship. So and it's a different marketing approach, a different delivery approach. So we heard be consistent with your pricing, right? Being mindful of employer groups having different pricing than consumers, thinking about that early on, making sure that in the conversation you are delivering value to the person on the other side of the table, right? And that can range from concierge clinics to executive health to telemedicine, right? Be flexible with how you approach those initial go-to-market conversations or even expansionary conversations, right? I mean, we have a few minutes left, and I do want to leave some time for Q&A, but did you find that your market offering shifted as you started to get larger and larger employer clients? Like, let's say when you went from your first couple hundred life groups to 1,000 life group, did your offering change at all?
Our offering didn't change.
Okay.
The logistics of serving them completely changed. The expectations of what they wanted completely changed. And we learned very quickly we need to justify what we're charging somebody. And we do that through doing claims analysis, total cost of care analysis, not like cost avoidance, because that's something that's like very arbitrary, but like really looking at what you did pre-implementation to post-implementation to year 1, year 2, following kind of a PEPY or per employee per year cost on a total cost of care to really see how is it trending and what are you impacting. What we found is that we started doing more things like flu clinics, on-site, vaccinations, and not something we started the company with, but when a company is that big saying, hey, would you do our flu clinics? The answer is yes, because I don't want Rocco coming in and doing the flu clinic and going, hey, we could do that too if you needed, So everything that when it came to big employers, it's like if they asked and it was within our scope, the answer was yes. We'll figure it out.
That's great. Rocco, how about you?
Right. No, we're very flexible, and we do work with our bigger employer groups. So we have
There's a client right
the
there.
horn blower. So that was the name of the ship. So we do have 2 different price points, so a price point for retail and a price point for employer groups, which remains consistent. But the services that we do when we started the clinic from day 1 till today is roughly the same. So a member doesn't know that an employer, whether they're an employer group or a retail, they get the same service. So there's no difference there. But one of the things that we do with our bigger employer groups is we will do health fairs, and we support them that way when they ask us to. Yes, definitely.
Right?
Yeah, I would say for us, we have expanded the services that we cover. We do the health fairs. We'll do on-site biometric screenings. We have a cool health risk assessment tool now. We also now offer a mental health service. In our community, mental health has been really big. It's been the #1 driver for our new accounts. Have been calling about mental health that we can provide. And telemedicine and things like that. And we're more so looking at this, like direct primary care is the core of what we do. But there's other services that we can provide these employers as, #1, a way to get in, but #2, a way to provide the value that they're looking for, because I don't want one of our competitors getting in there and doing that. We want all of our clients to eventually be direct primary care clients, but sometimes the way you get them, you have to be creative.
That's great. All right, we have just a little bit of time for questions from the audience, so go ahead.
Yeah, sure. DPC Coalition, we do a lot of outreach to employers and talk a lot about the value equation of DPC, but we all know they're very data-driven. And given perhaps the lack of, particularly for smaller practices, the ability to get claims data and share claims data because you're not, filing claims with anybody, which is part of the great thing about DC. I know, Ryne, you started to talk about this a little bit. How do you skin that cat? And how do you get the data? And how do you prove the data-driven value to the employer who's looking to, reduce cost on their total cost of care?
Yeah, thanks, Jay. So for us, we've partnered with Health Catalyst, formerly KPI Ninja. They've run our data since they started. And with the state of Nebraska client, we actually just published our updated report for 2022, 2023. And the way that we look at it is we pull all the claims data and we look at what's the claims experience per member per month for those that are not in direct primary care, and what's the claims spend per member per month for those that are in direct primary care. And that's at least one metric among others that we look at to say, is there cost savings here? Because we would expect people that are in direct primary care are not going to file as many claims as people that don't have access to one of our clinics. So that's just one way that we do it. But if you are going to be required to provide reports like that, it's important that you link up with a company that can support you. And we happen to use Health Catalyst.
Right. So I guess how we kind of solved it is we brought it in-house. So I'd mentioned her name. So Lacey, right there, she's our data analyst. So she pulls all the data for us and makes it make sense. So we know how many encounters we have with each employer group. And then we're able to come up with a dollar value for the services that we provide. And that's because we do it in-house now for the data.
Data, it's a topic we could talk hours on. Jay, we move upstream. We're trying, tap straight into the TPAs that are collecting data on all employees, whether they're DPC or not. That way we can really start bifurcating them into cohorts and really looking at how we're actually changing the trend line for clinical spend. Cohorts will go into, high deductible plans or, very rich plans based on the chronic disease that they might have. So you have to be able to really track them. And more importantly, you have to clean the data up, so whether it's KPI or whether it's, NavMD or Ninja or whoever, you need clean data and you need to be consistent and normalized, and that's probably the biggest complication. Getting the data is getting easier because people want to see something different than what they have. It's getting data that's interpretable and then actionable. That's the biggest thing with data right now.
That's great. Unfortunately, I'm getting the wrap-up sign, but I'll share, as our group's a little bit younger, we found TPAs were very surprisingly open to working with us. So if you can connect with that TPA, sometimes even the broker, actually, and that's a great chance to get in with the broker community. They may be willing to share, not always, but that's something that can be fairly effective too. So, well, thank you all for coming, and thanks, gentlemen, for joining.